Hi, my name is Maitre Patel. I work at the Mayo Clinic in Arizona, and my talk today is Aunt Minnie's Ovary, Patterns, Pearls, and Pitfalls in Ovarian Imaging. I have no disclosures to make on this lecture, and my objective today is to outline an algorithm for thinking about an adnexal mass when we see one on ultrasound, to review the sonographic appearance of a variety of types of physiologic and pathologic adnexal cysts, describe criteria that will allow you to make a confident diagnosis, and discuss if and when a mass that you identify on ultrasound needs follow-up or surgical intervention. Now, this is a categorization of adnexal disease from the perspective of a sonologist. You can see that these categories are rather idiosyncratic because there are some very specific categories like hemorrhagic ovarian cyst and some pretty broad categories like solid mass. But the reason why I like this categorization is that if we can put an adnexal mass that we identify in ultrasound into one of these categories, then we know exactly what to do with that in terms of any follow-up imaging or surgical intervention. Because that's the basic approach that the sonologist has to an adnexal mass. What you want to do is ask yourself, am I reasonably confident that I can put this mass that I'm looking at into one of those categories? Do I know what this is? If not, is there a subsequent test that might even include a follow-up ultrasound that won't harm the patient and that has a reasonable chance of showing characteristic findings to either avoid surgery or to improve surgical planning? Now, clearly, pattern recognition works when we look at the adnexa. There have been many scoring systems that have been developed to try to distinguish between benign and malignant adnexal masses. And the most extensively tested formula is this prediction model that's been put out by the IOTA, the International Ovarian Tumor Analysis Group. It's a mathematical model, and several studies have shown that this mathematical model works almost as well as pattern recognition by experts, but not quite. So I'll submit to you that the choice is yours. You can either learn to become an expert in pattern recognition when you look at these adnexal masses on ultrasound, or you can get out your calculator. Now, this is a silly slide, but this is actually the mathematical model that explains how you might be able to analyze an ovarian mass that you identify on ultrasound based on a variety of different criteria. Clearly, we're not going to be doing that at the view box on a daily basis, but it's important for us to understand how we fit into the picture as imagers. The management of adnexal masses is highly influenced by the sonographic impression that you will provide in your report. We want to strive to avoid unnecessary intervention because, remember, the vast majority of the masses you see in the adnexa of a woman are going to be non-neoplastic ovarian cysts, and most of these are going to spontaneously resolve. This is an algorithm that we'll be working through to try to help us in formulating recommendations for follow-up, for not having any follow-up, or for surgical intervention. And the first step in this algorithm is to decide whether the mass you're looking at is a simple cyst, a unilocular cyst. What do we mean by that? Well, we mean a cyst that lacks internal septations, that has no nodules, it has no wall irregularity, and it's oval or round in shape. If you can make the observations that lead you to confidence that you're dealing with a simple cyst, then the diagnosis has been established as either a non-neoplastic cyst or a benign neoplasm. Malignancy is practically excluded when you see a simple cyst. Now, it's important for you to have faith in that assessment. The risk of malignancy in unilocular cysts is practically zero. In a study of 3,000 unilocular cysts done in over 15,000 postmenopausal women, and these weren't just small cysts, these were cysts that measured up to 10 centimeters in size, the risk of malignancy was less than 0.1%, and that's with a 95% confidence interval. But what about those rare malignancies? Well, it turns out that in this series, those rare malignancies were always borderline malignancies. They were always over 5 centimeters in size, and they always had identified a change on a follow-up sonogram, meaning that septations or tiny wall nodules associated with the cyst were identified on the follow-up study. It's not clear whether those are new or whether they were simply missed on the first study. So, if the answer to the first question is that you are in fact dealing with a simple cyst, the next thing that we want to try to assess mentally is whether this is a non-neoplastic cyst or not. Predicting non-neoplastic cysts is important because it allows us to ignore cysts that are almost certainly self-limiting or clinically unimportant, or to follow or remove cysts that we think are not non-neoplastic cysts because they have the potential to cause harm, that harm being mainly that they'll enlarge in size and potentially become an emergency if they torse. So the 4 factors that we will look at to try to predict whether a cyst is non-neoplastic or not is to look at stability, if we're able to, location, size, and the patient's hormonal or clinical status. So let's assess those one by one. Now, stability is probably the easiest to understand. Clearly, if a cyst is decreasing in size between 2 exams, that's a non-neoplastic cyst. There are no instances that have been shown where a neoplasm actually got smaller on a follow-up study. And so if you can show that the cyst is decreasing in size, you don't need to treat that cyst. It's expected to resolve, should not be a problem for the patient. If a cyst doesn't change in size, it's also likely to be a non-neoplastic cyst, assuming that you've had a long enough interval of observation. Clearly, a cyst that's been there for 10 years and not changed in size is not a neoplastic cyst. The question is, how long do you have to wait to assess the absence of change in size? And we'll discuss that in a bit. If a cyst is increasing in size, I think at this point you have to conclude that it's probably a neoplasm, because non-neoplastic cysts typically do not progressively increase in size over time. Surgical removal, therefore, would probably be important to perform if the patient is relatively young, because the cyst will just increase in size until it gets quite large. And finally, if you can show that the cyst is rapidly developing, meaning that it wasn't there 3 weeks ago or wasn't there 3 months ago and now is there, it's almost certainly going to be a non-neoplastic cyst, because neoplasms do not grow like that, where they weren't there 3 months ago and now exist, at least not benign neoplasms, which is your differential diagnosis for a simple cyst in the ovary. And so if it's rapidly developing, you could ignore that cyst if the symptoms allow you to ignore it. Well, let's turn our attention to location then. If the cyst can be shown to be next to the ovary, it's quite unlikely to be a neoplastic cyst. Now, there are case reports of para-ovarian cystadenomas and even para-ovarian cystadenocarcinomas, but a good rule of thumb is that if you can see a separate ovary, the cyst is not going to be a neoplasm. A para-ovarian location also means that it's less likely to therefore require surgical treatment. And finally, size. And this is what most people want to pay a lot of attention to. Unfortunately, there really are no absolute thresholds that allow us to distinguish a non-neoplastic cyst from a benign neoplasm. There's no number below which everything is a non-neoplastic cyst and above which everything is a neoplasm. But there are some numbers that can be helpful. In patients who are still before menopause, if a simple cyst is less than or equal to 5 centimeters, it's very likely to be a non-neoplastic cyst. On the other hand, if it's over 7 centimeters, that's not very likely to be a non-neoplastic cyst, and therefore it's more likely to be a neoplasm. In postmenopausal patients, it somewhat depends on how many years they are away from their final menstrual period. But one can confidently state that if a cyst is less than or equal to 1 to 3 centimeters in size, it's more likely to be a non-neoplastic cyst. This is a simple cyst, of course. One thing we all should be on the same page on is understanding how we talk about adnexal cysts. How big is this cyst, where we have 4 different measurements, 2 taken in the longitudinal plane and 2 taken in the transverse plane? And it turns out that the Society of Radiologists in Ultrasound had a consensus conference, and this was back in 2009, and concluded that when we talk about adnexal and ovarian cysts, we should probably be talking about the largest measurement, at least as it refers to simple cysts and as it refers to things that are round or oval in shape. And so this cyst is a 4.4 centimeter cyst because the largest measurement is 4.4 centimeters. The hormonal and clinical status of the patient is quite important to consider. A non-neoplastic cyst is most likely if the patient is menstruating, but remember that a cyst that's simple in a postmenopausal woman is oftentimes non-neoplastic. In fact, about 50% of these simple cysts in postmenopausal patients will resolve on their own. Now, that resolution process typically will take about 1 to 2 years. Resolution is also much more common if the patient is within the first decade from her final menstrual period. So, because of that, in our laboratory at Mayo Clinic, we always will have an assessment of and a recording of when the patient's last menstrual period is, and we want to understand that in the context of when we're doing the study. We also have benefit of using the electronic medical record at our facility, and that helps us because the clinical status is just as important to consider. And I won't go through all of these notes, but this 21-year-old woman with the cyst that I'll show you had pain that started at 10 o'clock in the morning, and it hadn't got better, so she was concerned, but now the pain is dull and lessening. So it was a relatively acute onset of pain that's resolving. And so that is a very common scenario for a non-neoplastic cyst, and that will factor into our assessment. So in this algorithm, if we've decided that the cyst is unilocular, simple, and we've decided that it's unlikely to be a non-neoplastic cyst because it's increasing in size on follow-up, or because it's over 7 centimeters in size, we'll take action on that, and I'll be talking about that a little bit later in this lecture. But in many cases, the cyst will be one that we very likely will predict that it's a non-neoplastic cyst, and one that we don't even want follow-up on. For example, a patient who has a cyst that didn't have that same cyst 3 months ago, that's clearly a non-neoplastic cyst. One can conclude in the asymptomatic patient with these suspected non-neoplastic cysts that you can say something to the effect that in the absence of relevant clinical signs and symptoms, follow-up ultrasound is very unlikely to be necessary. In other patients where we're not sure whether we're dealing with a non-neoplastic cyst, but we think we probably are, we'll probably want to get a follow-up ultrasound to help us make that determination. So the important thing to try to do is distinguish when we're going to take this approach, where we're not going to get follow-up, and when we're going to take this approach, where we are going to get follow-up. Can we agree on some size threshold to help make that distinction? Well, the consensus conference did come to a consensus on this issue. For simple cysts, the experts in attendance for that conference agreed that really follow-up was not indicated when an asymptomatic woman had a simple cyst and she was premenopausal and that cyst measured less than or equal to 5 centimeters in maximum diameter. There was a little bit less consensus with respect to the size cutoff in postmenopausal patients. All of the participants understood that 3 centimeters could be used by reasonable practitioners of imaging and basically say that a postmenopausal patient with a simple cyst less than 3 centimeters might not need follow-up, but realize that some people might want to follow up cysts between 1 to 3 centimeters. And so basically advocated that the threshold between 1 and 3 centimeters could reasonably vary between practices based on how important it was to that practice not to mistake a benign neoplasm from a non-neoplastic cyst that's asymptomatic. So again, the SRU criteria for ignoring a simple cyst: asymptomatic patients, less than or equal to 5 centimeters if you're premenopausal, and less than or equal to 1 to 3 centimeters, you get to choose if it's postmenopausal. Now, my criteria are slightly different. what I would advocate is that many of the patients that we're imaging actually do have some vague symptoms. So if the symptoms are vague and then go away, I would consider that to be an asymptomatic patient. And so they don't have to be asymptomatic at the get-go. If it's less than or equal to 5 centimeters, I agree, a premenopausal patient would not need to be imaged again. And in our practice, we use 2 centimeters as the threshold. So a postmenopausal patient with a simple cyst that we've well evaluated that's less than 2 centimeters would not need to have follow-up imaging. And finally, I've added a new criteria. If you've seen the cyst as a new finding, so that you, in other words, saw the ovary as a normal structure within the last 6 months on an ultrasound, and now you see a cyst that's simple, that cyst does not need follow-up, because that cyst, almost by definition, is going to be a physiologic, non-neoplastic cyst. Now, it's important to understand why you're following the cyst. This is oftentimes confused by people. You're not following the cyst to determine if the cyst is malignant or not. You've already made that determination. Remember, by calling it a simple cyst, you've practically excluded malignancy from the diagnosis, especially if the cyst is less than 5 centimeters. No, the reason you're following the cyst is to determine if the cyst is more likely to be a benign cystic neoplasm or a non-neoplastic cyst. So, with that in mind, if you're presented with this set of images and this clinical scenario, a 55-year-old woman who's asymptomatic and has a 4 centimeter cyst, when would you perform the follow-up study? There can be a number of potential choices that you would make, but in my estimation, the proper choice is 6 to 12 months, not 3 months or 6 weeks, as many people reflexively would do for a premenopausal patient. And the reason for that is that if this is a non-neoplastic cyst, as we predict it probably might be, versus a benign neoplasm, your distinction between those two is going to rely on time to decide whether the cyst is stable or decreasing in size, in which case it's a non-neoplastic cyst, or increasing in size, in which case you can predict that it's going to be a benign neoplasm. And so if you take a look at that, the expected size of a 4 centimeter cyst over time, if it's a moderately enlarging benign neoplasm with a doubling time of, let's say, 180 days, in 6 weeks, if you image that patient again, it would only be 4.2 centimeters. And you will not be able to tell that it's actually changed in size. In fact, you're very likely to make the erroneous assumption that it hasn't changed in size, when in fact it is slightly increasing in size. And so you need to give yourself enough time to be able to distinguish whether the cyst has actually changed in size. And this is even more true the smaller the cyst becomes. A 2 centimeter mass over time, if it's doubling in size every 180 days, would only be 2.1 centimeters in size if you looked at it in 6 months. You will not be able to make that diagnosis of enlargement. Whereas if you look at it in 6 months, it'll be 2.5 centimeters in size and will clearly look different. So, if it's a simple cyst and you're going to follow the cyst because it falls into your follow-up criteria, you need to pick a reasonable interval for that follow-up. The Society of Radiologists and Ultrasound, as a simple rule, stated that if it's a premenopausal patient and if it's an over 5 centimeter simple cyst and you're going to follow it, get the follow-up in 12 months. Again, remember, these are asymptomatic patients. If it's a postmenopausal asymptomatic patient and it's above your threshold, which is between 1 and 3 centimeters, again, they said get a 12-month follow-up. And keep getting that 12-month follow-up until you're fairly confident that either the cyst has resolved or is resolving or isn't changing in size. There really weren't any recommendations on when to stop the follow-up. Again, I've modified this a bit for my practice, which I think is reasonable. What I do is in the premenopausal patient, if I'm going to follow the cyst, I'll get the first follow-up in 3 months. Not because I know that I'll be able to make a change in assessment of the size of the cyst if it's enlarging. On the other hand, most of those cysts between 5 to 7 centimeters that are simple are in fact going to be still non-neoplastic physiologic cysts. And they clearly will demonstrate resolution or change in size for the smaller within 3 months. If it's a postmenopausal patient and the cyst is over 3 centimeters in size, I'll get the first follow-up in 6 months because that gives me an opportunity to make an assessment as to whether the cyst is increasing in size and gives me another chance to look at the margins of the cyst to make sure that I really believe that it's simple. On the other hand, if it's a smaller cyst, between 2 to 3 centimeters in size in postmenopausal, I do a 12-month follow-up. And I'll cut these intervals in half if there's anything about the cyst that makes me feel a little queasy about it. We'll get a follow-up sonogram yearly, and then we'll double the interval of the follow-up as long as it's stable. So in other words, if the cyst is stable after the first year, we'll get the next follow-up in 2 years. If then it's stable at 2 years, we'll get the next follow-up in 4 years, and so on and so on. So again, the SRU consensus criteria, no follow-up needed if it's less than or equal to 5 centimeters in a premenopausal patient, less than or equal to 1 to 3 centimeters, you pick the threshold in a postmenopausal patient, get a follow-up yearly if it's over 5 centimeters or above that threshold, and still less than 7 centimeters. And if it's over 7 centimeters, you might consider a surgical consultation. Now, back to the algorithm. Let's say you've decided that the cyst or mass that you're looking at is not a simple cyst. The next question then is to say, could the findings that are making you decide that this is not a simple cyst be due to a physiologic process? Well, what are those physiologic processes that can cause concern but really should not? Well, one of them is if you see two simple cysts next to each other. So adjoining cysts can simulate an intervening septation. The corpus luteum, which is sometimes cystic and sometimes involuting, can have wall irregularity or even look like a small solid mass. And finally, hemorrhage can have a confusing appearance that can simulate septations and nodules. These are 3 physiologic events that can cause us to worry about a cyst. Here are some examples of adjoining cysts. In both of these cases, this could reasonably be interpreted by an imager as a possible septation, although I think there are clues in both cases that suggest that these are not septations, but rather an intervening area of parenchyma between 2 cysts. Here's another case of 2 simple cysts actually separated by ovarian parenchyma. Now, I know that they're simple cysts because I know the outcome, but I think it would be a reasonable conclusion for somebody to make to say that this is not a simple cyst, that this might in fact be a septated cyst. And so you would not be able to say that that's a simple cyst. Note that the presence of blood flow within this pseudoseptation does not really allow you to be more worried about this as a neoplastic septation because trapped ovarian parenchyma between 2 simple cysts, as in this case, will have blood flow. Here's the other spectrum of change where a cyst that is physiologic in both of these cases actually has wall irregularity because of involution of the cyst over time or because of wall-based clot. And in fact, corpus luteums oftentimes look like small solid masses. They don't look cystic at all. So here, if you were really to look at this and categorize it, you might be worried if you didn't have a lot of experience that this was a small solid mass within the ovary. But in fact, this is the corpus luteum as manifest by this ring of flow around the cyst. Hemorrhage can be very confusing to the uninitiated, but you want to look for fibrin strands, but it can look like septations. It can look like wall nodules. Now notice that this wall clot actually has a different echogenicity than the wall itself. So that's one clue that you're dealing with a clot and not a wall nodule, because if this was a wall nodule growing from the wall, it should have the same echogenicity as the wall itself. The other clue is the shape of that nodule. So the key ultrasound features of a hemorrhagic ovarian cyst are that there are internal echoes, which can be clumped, as we see in these instances, oftentimes with a lace-like or fishnet appearance. And so these are not septations. these are fibrin strands within a sea of clot. And the retracting clot sign is very useful for you to look for. So again, as I mentioned before, this wall-based clot isn't a mural nodule because it doesn't have the same echogenicity as the wall, but also has these concave margins or straight margins that allow you to be confident that you're dealing with clot. Now, if you suspect clot on the wall of the cyst as a possible cause for the irregularity of that cyst, you want to test that hypothesis by applying color Doppler, because clot really should not have blood flow, as we see in these cases. Another useful feature to suspect a physiologic process is this circumferential flow. So if I see ring flow around a heterogeneous cystic area, I'm not worried as much about this being possible wall irregularity because it has the characteristic signature on Doppler of a corpus luteum. So if the cyst or mass that we're seeing isn't a simple cyst, but we decide that the findings that we're seeing are reasonable for a physiologic process, then we're back to this side of the equation where we want to decide whether we're going to follow this at all or not. Cysts that are due to hemorrhage do resolve over time. So that's one thing in our favor. If we think it's a physiological process, it should change. This is a landmark article that showed that hemorrhagic ovarian cysts, when scanned on a weekly basis for 3 months, 30% of them would resolve within 2 weeks, and 100% of them in this series resolved in 8 weeks. Now, there are anecdotal cases, both reported in the literature and in my own experience, that take longer than 8 weeks. So, although 8 weeks is a very good time frame to expect all hemorrhagic cysts to have resolved, sometimes they take a little longer. There's really no data to suggest that the size of a hemorrhagic cyst really matters in its eventual resolution. So, based on this evidence, the SRU Consensus Conference decided that if you had an asymptomatic patient with a hemorrhagic ovarian cyst based on the sonographic appearance, you really didn't need follow-up at all if it was less than or equal to 5 centimeters in size, and you could be confident that it was a hemorrhagic ovarian cyst. In other words, it had the classic features of a hemorrhagic ovarian cyst, those being the presence of fibrin strands, the presence of retracting clot, the appropriate history, and circumferential flow. You should get a short interval follow-up in 6 to 10 weeks when it was over 5 centimeters, or if the findings were suggestive but not classic. So if we get to this stage and we decide that no, the findings are not reasonably due to a physiologic process, or they might have been due to a physiologic process, but because we followed it and it hasn't changed, or because it's over a certain size, we can't be reasonably certain that this is a physiologic process, then we want to go to the next step in the algorithm and say, are there findings to suggest a specific diagnosis? So this is our list of diagnoses. And if we're looking at specific diagnoses, yes, we can make specific diagnoses for a number of these. So let's first talk about the endometrioma. And the advantage of being able to make a specific diagnosis with some confidence on ultrasound is that then the patient can be treated and managed as appropriate for that expected diagnosis, and surgery is not always what is needed, especially for endometriomas. Endometriomas have been evaluated for many years on ultrasound. There's lots of literature in this regard, but recognize that the vast majority of studies that looked at the characteristics of endometriomas really didn't test those characteristics against the competing diagnosis of acute hemorrhagic ovarian cyst. And you need to recognize that acute hemorrhagic ovarian cyst can mimic endometriomas in premenopausal women. Now, endometriomas can be found in pre- and postmenopausal women. And the other key concept here in endometriosis and endometriomas is that it's been clearly shown now that patients who desire fertility, who want to undergo IVF, have reduced ovarian responsiveness if you have a surgical intervention for their endometrioma. So nowadays, if an infertility patient has an asymptomatic or relatively asymptomatic endometrioma, it's best thought to leave it alone, not to take that out. It's a don't touch lesion because the patient will have better ovarian responsiveness to IVF if you don't do the cystectomy. So this patient, who has two masses, one in each ovary, has two endometriomas, and they're both showing the classic appearance of diffuse ground glass echoes or low-level echoes. Notice how the echogenicity of those echoes is different within each endometrioma. Here's another patient that has an endometrioma with diffuse low-level echoes. However, this patient who has two small masses with diffuse echoes does not have an endometrioma. In fact, this is one of the pitfalls, is not understanding that acute hemorrhagic ovarian cyst can mimic this appearance. And in fact, this patient had two acute hemorrhagic ovarian cysts which resolved on follow-up. So to help distinguish acute hemorrhagic ovarian cysts from endometriomas, one can observe and look for these hyperechoic wall foci, these bright dots on the wall. Now, what are these bright dots? Well, it's thought that what these are cholesterol deposits from the lysed red blood cells. Remember that red blood cell membranes have cholesterol in them. All cell membranes have cholesterol. When they lyse, as they do in an endometrioma, and fall to the edge of the endometrioma, there are phagocytes in the ovarian parenchyma that will chew up that cellular debris. The cholesterol is indigestible. It gets stuck in those phagocytes and then forms these echogenic foci, which resemble the cholesterol deposits that one would see with adenomyomatosis in the gallbladder. In fact, that's what we think these things are small cholesterol deposits on the wall of a chronic cyst. Now, this doesn't happen only in endometriomas, but the good news is that these things do not happen in acute hemorrhagic ovarian cysts. So if you use a diagnostic criteria of the presence of low-level echoes, the absence of neoplastic features, and hyperechoic wall foci, you're only going to capture about 30 to 40% of endometriomas, because most endometriomas don't have these hyperechoic foci. But you will not mistake any acute hemorrhagic ovarian cysts as endometriomas. The likelihood ratio for endometrioma with this diagnostic criterion set is 32, which is quite high. This is what you would get from a series, and this is actual data, if you use the criteria of low-level echoes with no neoplastic features and not considering whether or not they had hyperechoic wall foci. So yes, most endometriomas, in fact probably all endometriomas, have low-level echoes with no low-level echoes. Sorry, not absence of neoplastic features, but low-level echoes. But unfortunately, many acute hemorrhagic cysts also have diffuse low-level echoes. Now, I want to be sure that you don't mistake the bright foci that I showed you on those other cases with something like this. This, yes, has foci of increased echogenicity, but they're not clearly on the wall. They're on the edge of this mass, and although there are low-level echoes in this mass, this proved to be a borderline cystadenocarcinoma, and these are small wall nodules. These two cases actually were not cancers. These are endometriomas, but you have to worry a bit about the possibility of neoplasm based on the ultrasound imaging without Doppler consideration. So here, this focal wall thickening should be viewed with some concern for the possibility of neoplasm. Now, the fact that we didn't see any blood flow in here may predict that this isn't a neoplasm, but clearly this hasn't been fully tested. And when we start implementing contrast enhancement or we use MRI, we would have more confidence that this doesn't have any blood flow in it, in fact is just clot adherent on the wall of this endometrioma. Whereas this nodule in this mass has blood flow, but actually this also proved to be an endometrioma. And this mass, which we don't see much blood flow in, if any blood flow in this mass, but it has convex margins, can't be assumed to be an endometrioma. And in fact, this was another borderline cystic cancer. There is a small risk of future cancer in endometriomas if you're watching these endometriomas, if you're not taking them out. There's a 1% risk of cancer developing in an endometrioma over time. Typically, these masses are over 6 centimeters in size. And in fact, most of them are quite large, over 9 centimeters in size. And typically, the patient is older. But this is why the SRU recommended that we follow endometriomas if we don't take them out. So the recommendations that one might put together are that you would get short interval follow-up prior to surgical intervention. If you were going to intervene on what you thought was an endometrioma, you probably want to get a short interval follow-up prior to surgically intervening if you don't see those hyperechoic wall foci. So if you see low-level echoes, but you don't see those hyperechoic wall foci, you need to exclude the possibility of acute hemorrhagic ovarian cyst. And typically there's no clinical urgency to intervening, so wait a few weeks and get the follow-up sonogram in those cases. If you're not going to do surgery, if the patient isn't going to have surgery because they're asymptomatic, and you suspect an endometrioma, a yearly follow-up is probably indicated because you'd like to increase your confidence in the diagnosis by showing that this is not increasing in size, and also monitor for that small but definite risk of malignancy developing within the endometrioma. So based on that, the SRU recommended that the initial follow-up for suspected endometriomas be at 6 to 12 weeks to ensure that the mass is not an acute hemorrhagic ovarian cyst, assuming that you don't see those hyperechoic wall foci, which could probably obviate the need for the 6 to 12 week follow-up. And then a yearly follow-up if it's not surgically removed to ensure that you're not mistaking a benign neoplasm as an endometrioma, or to be sure that there's not a malignancy that develops. Now let's turn our attention to cystic teratomas. Again, if we can make a specific diagnosis, we could manage these as expected for cystic teratomas. Most of these will go to surgery, but if the patient wasn't a good surgical candidate, you could certainly elect not to take out an asymptomatic teratoma. There are certain features that have been well characterized and well associated with dermoids. And these include acoustic impedance, as we see here, regional or diffuse bright echoes, as we see here, hyperechoic lines and dots, the so-called dermoid mesh, which we see here, and in this sagittal transvaginal image, the fluid level, which has also been associated in the literature with dermoids. Now, one pitfall when you're evaluating dermoids, or when you're evaluating the pelvis and a dermoid is there, is you may go completely unrecognized by the sonographer. So you need to be somewhat aware of the possibility of these dot dash appearance mimicking bowel. So this longitudinal image of the uterus did not recognize the fact that there was this large mass in the cul-de-sac. And in fact, on review of the images, we saw that there was this area here. Could this be bowel? Possibly. But it had enough of the features of dermoid that we wanted to go back in and make sure. And in fact, this turned out to be quite a large dermoid sitting in the cul-de-sac. Here's another case of a dermoid that has a very heterogeneous appearance. Now, focal acoustic impedance is an important thing to look for, and so sometimes to help you find that, you want to look past the finding and see if there is a swath of decreased echogenicity that you can see in the tissues behind the mass. Dermoids can be found in pre- and postmenopausal women. It's the most common ovarian neoplasm, and it's the one that's most subject to observer variability. This is a very interesting article that showed that even the same observer looking at a dermoid at 2 points in time may come to different conclusions about the mass. Here in this particular study, where 110 different types of lesions were evaluated by reviewers at 6-month intervals, meaning that the same set of images were looked at 6 months later, the observers did not agree with themselves for how they would diagnose the mass when it was a dermoid as much as you might expect. And inter-observer agreement is even worse in the diagnosis. Experts do pretty well in evaluating dermoids. So these are two early articles back in 99 and 95 using the criteria, and these are both from Europe, using the criteria of an echogenic ball, and this is the exact terminology that was used in these papers, in the corner of a cyst or filling up the whole mass, or the presence of echogenic lines and dots, or the presence of shadowing. These investigators showed that the likelihood ratio using these criteria was quite high for making the diagnosis of dermoid. Yes, there were some false positives, but this is a pretty good likelihood ratio for the diagnosis. But it's important to remember that all of those studies were performed by the physicians interpreting the examination. Even in Europe, where it is more common for patients to be scanned by physicians and then to be interpreted, those scans to be interpreted by the same physicians who scan the patients, if you just look at images, the experts don't do as well. And here the likelihood ratio for the diagnosis of dermoid varied between 7 to 12 using those criteria, even in the most expert sonologists that were looking at the cases. Well, how do you make mistakes when you're looking and thinking that you're dealing with a dermoid? And here's an example from the paper that Guerriero wrote in 2009 that gives us an insight into how mistakes are made. All of the operators in Guerriero's paper showed or suggested that this was going to be a dermoid because of the increased echogenicity in what was suspected to be this part of the mass. And I think that you can make a mistake when you diagnose a dermoid by relying too much on the echogenicity of the mass. So we looked at a different pattern approach and said that if you saw multiple patterns of dermoids, you were on far stronger ground for making that diagnosis. So what do we mean by that? Well, clearly increased echogenicity can be a feature of dermoids. When we looked at this, of the 74 dermoids in the series we looked at, a good 60%, almost 60% of them had increased echogenicity. So this transabdominal and this endovaginal image of two different dermoids show a mass that has increased echogenicity. And here, increased echogenicity, which is defined basically as echogenicity in the mass that matches that of the surrounding fat. But if that's the only feature of the dermoid, you can make a mistake. And in fact, this is a dermoid, but this is not a dermoid. This is an endometrioma. So not everything with bright echoes is a dermoid. Hemorrhage can also give you bright echoes. What you really want to look for is multiple features of dermoid. So as we showed in that earlier image, reproduced here, if we can see more than one feature, as occurs in 75% of dermoids, then we'll be far more confident that we're dealing with a dermoid. In fact, in this paper that we wrote many years ago, when any combination of two features or more were seen, there were no false positives in our series, giving us a likelihood ratio for the diagnosis of dermoid that exceeds 132, using the criteria I have described. So you want to look for multiple features of dermoid. Look for acoustic impedance. Look for increased echogenicity. Look for the dermoid mesh. It turns out that the fluid level by itself is not a very good feature, but in combination with those other features can be helpful. And if you see more than one feature of a dermoid, then you can be very confident that you're dealing with a cystic teratoma. You also do need to check for internal blood flow, because if it's present, the diagnosis is not a benign cystic teratoma. You would have to consider something else, such as a fatty exophytic uterine mass, like a lipoleiomyoma or leiomyoma, or potentially a malignant teratoma or struma ovary. And in these instances, if you can't make one of these diagnoses, but you see blood flow within what looks like a dermoid, you can't call that a dermoid, and you should consider an MRI. So, for example, in this case, this looks like a dermoid based on the images. This was an adnexal mass in the right adnexa. It has increased echogenicity in one area. It definitely has the acoustic impedance. But before we call it a dermoid, we put color flow on it, and in fact, this has blood flow in it, so it can't be a cystic teratoma. This could have been a number of things, and it turned out to be an exophytic lipoleiomyoma. Now, the growth rate of dermoids is slow. One study suggests that it can differ based on whether you're pre- or postmenopausal patients, but the vast majority of those dermoids grew only a few millimeters a year. The other thing to remember is that dermoids can transform into malignancies, especially when the dermoid's large. This doesn't occur very often. The rate is around 1% if you average 3 studies. These dermoids were all over 10 centimeters in size in one study, and the mean was 14 centimeters in size in another study. So these are not usually small masses. Based on this evidence, the SRU recommended that if the ultrasound was suggestive of a dermoid, but not pathognomonic, you should probably confirm that with an MRI or other imaging. If it is a dermoid in your mind on the ultrasound, you might consider an initial follow-up in 6 to 12 months, just to be sure that you haven't made a diagnostic error. After that, a yearly follow-up might be indicated if you don't take out the dermoid, just to monitor the growth over time, because there is a small risk of malignant transformation. Okay, let's turn our attention then to hydrosalpinx and peritoneal inclusion cysts, 2 things that occur outside the ovary. If we can find specific diagnoses or specific findings that suggest these diagnoses, then we may not need to do any surgery at all. There are some features that suggest hydrosalpinx, a mass that's cystic and tubular that's separate from the ovary, with incomplete septations or short linear projections. There has been a picture that's been called beads on a string, which I'll show you, which are small round projections representing the endosalpingeal folds along the wall of the fallopian tube. And the waist sign is another important feature that can suggest that you're dealing with a hydrosalpinx. So here's a hydrosalpinx that has a number of these features. It has an incomplete septation, as we see here. It has the waist sign, which is where you have an indentation along the wall of the mass, and you go completely 90 degrees opposite to that, and you see another indentation. So this is a hydrosalpinx. Now, by itself, some of these findings are more useful than others. So the likelihood ratio for incomplete septation is only 2, because some cystadenomas will have incomplete septations, as in these 2 cases. Similarly, the presence of small linear projections or small round projections, as we see here, by itself only has a pretty low likelihood ratio, whereas tubular shape and the waist sign are much more useful as isolated findings. But the real advantage comes when you combine observations. So if it's a tubular cystic collection and has an incomplete septation, it's about 7.4 in terms of the likelihood ratio. But more importantly, if it's tubular in shape and has the waist sign, it was always a hydrosalpinx in our experience. So you really want to look for multiple features. So if you're presented a case like this, where you see some incomplete septations, but you're not seeing a tubular shape, you're not really seeing other features that might suspect you to think that this is a hydrosalpinx, although there is a little bit of a waist sign here, as we see here. The best thing to do is to watch a cine clip or watch the sonographer scan, because that can be very useful in showing you that this is a folded tube that is a hydrosalpinx. And if it looks like a hydrosalpinx and you're confident of that, you could ignore it if the patient is asymptomatic. Now, peritoneal inclusion cysts can be very confusing, especially to those who haven't seen a lot of these. But once you get the hang of it, these can be very, not easy to diagnose, but can be very nice to diagnose, because what happens is you take the situation where the patient is suspected to have a malignancy based on the appearance, and with your experience you're able to say, no, this isn't a malignancy, we're just dealing with the peritoneal inclusion cyst. So what are we looking for? Well, peritoneal inclusion cysts typically have angular margins, especially as they abut what looks like to be solid tissue. Then if you look more carefully at the solid tissue, look for the presence of follicles, as we see here, and the presence of strands that come off from the tissue at right angles, the spider webbing of the peritoneal inclusion cyst. Here's another example of a cyst with, at first glance, you might have thought a solid area, but in fact, this angular margin, okay, is this solid? Well, it has small follicles. These features should make us think of a peritoneal inclusion cyst. And if it looks like a peritoneal inclusion cyst and you're confident of that, you can then ignore it. Turning our attention to masses that have other features. So here's a cystic mass that doesn't have angular margins, doesn't have the strands. The solid area, there's not really much of a solid area, but there's certainly septations here. This has no features of hemorrhage. When we encounter a mass like this, a multilocular cystic mass with septations, albeit rather uniform and thin, we need to think about a neoplasm. And especially in the setting where there are septal nodules and wall nodules. Clearly here on these two different examples, this has to be viewed with a very high suspicion for malignancy. Again, this is that model to predict malignancy, and it's a little bit silly to actually even show you these numbers. It's crazy, right? But I'm showing you mainly to show you the inputs to the data, because if we understand the inputs to the data, we can see how important ultrasound is in making this diagnosis. The full model shows you that there are only 4 clinical parameters that have any influence on whether a mass is going to be a cancer or not. The other 8 parameters are all imaging parameters. The diameter of the lesion, the presence of ascites, blood flow in the solid area, whether it's purely solid, whether the solid area has a sizable component, the irregularity of the cyst wall. If there's acoustic shadowing, that is actually a negative predictor for malignancy, and the color score. And even in the simple model, if you even simplify it and use the simple model, mathematical model, which we're not doing, of course, you can see that the clinical parameter, the only clinical parameter that really makes a difference is how old the patient is. Everything else is an imaging feature. So it's not appropriate for you as an imager to say clinical correlation necessary to review whether this mass that I'm seeing is a malignancy or not. That's not a very useful thing, because you can make the clinical correlation, because the patient age is really the only thing that matters. CA-125 doesn't help you. It's not of additional value. In fact, expert subjective impression performs about as well as the mathematical model, and that's important to realize. So when you're trying to make that subjective impression, certainly take into consideration the patient's age. Look for ascites, and look to see whether the mass has irregular walls, thick septations, papillary projections, solid areas, the degree of vascularity. These are the things that will allow you to predict malignancy. And if it has those things, you want to make the diagnosis of malignancy and send the patient to surgical evaluation. So in conclusion then, this is the full spectrum of our algorithm. We're going to first see whether the mass is a simple cyst or not. If it is, we know what to do. If it's not, we know how to analyze it to see whether it might be due to physiology, that it's causing us to be confused. If that's not the case, there are specific things we want to look for. We will then consider the possibility of MRI to help us in the diagnosis if we haven't found specific things that allow us to make the diagnosis. And in the end, some patients will have to have a surgical diagnostic procedure performed, but the vast majority are going to be patients where you know what to do based on your sonographic evaluation.